電噶嘛，行樓部唔得啦。呢個係另外一個戇居嘢嚟啊！部真係冇電，大家好戇居。
好穩陣㗎啦。
插電就安全。
係啊，係 線
係啊，咁啊安全啦。
係啊，WiFi 嘅話有時
跳下跳下噶嘛會窒噶嘛會。
係啊係。
喂，嗰啲俾信咗我哋，你放心啦，我哋3個 IT 睇住㗎，你放心啦。如果真係突然間即係 technical 就應該冇問題嘅，你話突然間停咗電嘅，我幫你唔到啦。除咗呢樣。係。
唔係佢哋印度啲 IT 又好掂嘅，佢哋啲好勁嘅。同埋我諗佢哋唔係第一次做嘅。
係我好耐嘅。其實而家我哋間公司咧最近點樣咧？申請所有加咗150 IT 全部喺印度請。係嘛？係啊，淨開個新嘅 department，將所有大部分應該新加喺美國嘅 IT 全部喺住晒印度。我哋個 office 喺叫 Bangalore 嗰個地方就係等於印度嘅等於美國嘅矽谷。係嘛？係啊 ，IT 城，好多啲 IT city、IT 嘅 company 喺度 set up 㗎。搬家喎。唔該晒。先不如劈埋件褸嗰度。我試過，係咯，我試過，得啦，咁得㗎啦，我記得㗎啦，劈埋嗰邊得㗎啦。我搣咗個 copy 係嘛？搣咗咩 copy？唔該晒。係啦，呢張凳矮啦，你睇我坐到咁埋啦，我都唔會斬咗個頭。係咯。使唔使睇嗰啲啊？呢一個位有冇頂住？中間有嚿。OK， 我攬住佢。係喎，呢度頂住嘅。睇先嚇。近過少少。近過嗰邊好啲。嗰邊。係啊，嗰邊會好少。呢度我用以前嘅油啫。你用唔用呢個？呢個冇用嘅。唔用呢個。呢個先有用嘅。係啦。隻貓手用。係啊。嗰個冇用。係啊。嗰個現場全班人喺度有用。係擺喺度先啦。通常呢邊少啲嘢，嗰邊多啲嘢嘅。哇！用呢個方法真係可以嚇，即係無遠弗屆啦嚇，啲好㗎，都大啦。你嗌佢有啲人真。
Yeah.
Move your mouse on the video screen. You can see a green button at the bottom. Share screen.
Share screen.
Yeah, and then select PPT PowerPoint.
我哋睇到個疤喎，個疤你唔知咯，
我哋開嚟睇咪知咯。
乜佢睇唔到得㗎啦，我睇到冇問題啊，我仲睇到好多嘢添，仲睇到上面呢啲添。
因為佢可能俾你睇，因為你要。
So may I know if there's anybody introducing me or I will introduce myself?
You have to introduce yourself, sir.
Okay, no problem.
Yeah.
咪即係個 typical 嗰邊啊，係啊，即係今日做緊一個 education video 咁咯，好似係啊，呢個我都玩過嘅呢啲係，有啲咧就有主持人嘅，有啲就冇。我試過咧係唔係望呢個嘅，係用鏡頭拍住我，有個主持人坐我隔離一齊傾偈。 Hi, good evening, my friends in India. How are you? I'm Henry Chen from the Chinese University of Hong Kong. I'm very happy this evening to share with you some of the new data and insights in the treatment of hepatitis B in the area of tenofovir alafenamide. So hepatitis B is a worldwide problem, and the burden of disease is actually highest in Asia. In Southeast Asia, 39 million people are infected by hepatitis B, and in India, it has a big population of HBV patients, and more than 1.25 billion of people have hepatitis B with a 3% prevalence in the country. So India is likely to have more than 37 million HBV carriers. So this is a huge problem in India. And right now, we have two classes of drugs. One class of drug is a parenteral antiviral. So it is mainly interferon based. The key registered drug is PEG interferon alpha 2A by Roche. And in some countries, alpha 2B is also registered. The traditional one is interferon alpha. The other group of drugs are oral drugs, and these are nucleoside or nucleotide analogs. We call NUTs. The first drug was lamivudine, followed by Tenofovir. Right now, we have 5 drugs registered Entecavir, Terbinafine, and also Tenofovir, Disoproxil, Fumarate, we call TDF. So TDF is one of the first-line drug recommended for use in all international guidelines. And right now, we have 8-year data from a phase 3 study. As you can see from the slide, if we look at both E-positive and E-negative patients in observed population, that is for those patients who have been really followed for 8 years and we do not count the dropouts, more than 97% of all patients can achieve an undetectable HBV DNA. And some patients can achieve S loss. It's commonly seen in commonly seen in E-positive patients, up to more than 10% of patients as loss in ITT analysis. In negative patient, it is less common. It's only about 1% after 8 years. So S loss is still not a common observation after prolonged TDF therapy. But even with no S loss, with just viral suppression, after 5 years, we see reversal of liver fibrosis and cirrhosis. So this is in contrary to what we believe in the conventional textbooks, that cirrhosis is irreversible. As we can see in a 5-year biopsy cohort among patients on TDF, a large proportion of patients actually had histologic improvement. And we look at the figure on the right side. So this shows the number of patients with reversal of fibrosis starting from a cirrhosis stage. As you can see, majority of patients actually has reversal of cirrhosis or regression of cirrhosis. Most and only a minority of patients had a stable fibrosis stage, and only one single patient had increase in fibrosis, that is ESHAC score increased from 5 to 6. TDF is safe. So after 8 years of therapy, only 2.2% of patients discontinue the drug in the phase 3 study. Only 2.1% of patients died. I mean, minority of patients have serious adverse events or grade 3 to grade 4 adverse events. We most worry about the kidney and the bones. But if you look at more serious renal impairment, creatinine and a high creatinine, low phosphate, these are actually not very common. So overall, most patients actually do have a good safety profile. They can continue TDF for a long time without discontinuing the drug and without any serious adverse events. So because of that, TDF is one of the drug recommended by all treatment guidelines. So we read the PASO guideline in 2015, the ASLD guideline in 2016, and the most updated EASL guideline in 2017. TDF is one of the preferred first-line therapy. And the other preferred first-line therapy is Entecavir. And the most recent EASL guideline, TAF, that is Tenofovir alafenamide, is also one of the recommended therapies. So I will spend more time into Tenofovir alafenamide, we call TAF, in my subsequent presentation. So Entecavir is a good drug, but it's not perfect. If you look at treatment-naive patients, it is really good. For 5-year data, 1 to 2% of patients develop drug resistance. Majority of patients, they do not develop drug resistance on Entecavir. But however, for those patients who has exposed to lamivudine, then this is totally different, because Entecavir share the resistant mutation motifs with lamivudine. So for those patients with pre-existing lamivudine resistance, particularly in the 204 position and 180 position of the polymerase gene, they have a higher tendency to develop Entecavir resistance. So after 5 years of treating lamivudine refractory patients, about half of them will have Entecavir resistance. So this is a group of patients that we do not want to use Entecavir. So we go back to all the treatment guidelines. For those patients who have developed resistance to lamivudine or developed resistance to Entecavir, we should switch to TDF. We now know that we do not need to add on. We do not need to add TDF to Entecavir or lamivudine. We just need to switch. And with the availability of TAF nowadays, the EASL guideline also recommends that TAF is an alternative to TDF in patients with Entecavir or lamivudine resistance. So up to today, TDF is still one of the key molecules to treat hepatitis B. But there are some limitations of TDF. We have looked into the Hong Kong data. We've studied more than 55,000 Hep B patients for about 5 years. And we look at the bone and renal side effects. It means we look at renal failures, dialysis, fracture of the spine, fracture of the hip. And there's only a slight increase in the risk for patients on nucleotide, that is Entecavir, versus nucleoside therapy, that is Entecavir and lamivudine. In our study, only a small proportion of patients were on Tenofovir, because at that time when we performed the study, Tenofovir was not readily available in Hong Kong. And the only risk was hip fracture, but the overall risk was still very low, only 0.21% in patient nucleotide, that is predominantly Entecavir therapy, versus 0.18% of patient nucleoside therapy, that is for patients on lamivudine and also on Entecavir primarily. And because of that, ASLD recommended that there should be no preference between Tenofovir and Entecavir regarding a long-term risk of bone and renal complications. But however, the renal toxicity of Tenofovir has been well documented, and for the bone toxicity is also well documented, although it's uncommon, but it's there. So we know that some patients may have renal impairment, and some patients may have reduced bone mineral density, and also there's increases in markers of bone turnover among patients on Tenofovir. So here I share with you some of the data from various cohort studies all over the world. As you can see from study in Spain, TDF was associated with high risk of this is retinol binding protein excretion. This is a protein expressing the tubular function of the kidney. Higher RBP excretion means that there's a tubular leak of protein, indicating a mild tubular toxicity of TDF. In a Taiwan study, TDF was associated with high risk of acute kidney injury. In an Italian study, there is a problem of phosphaturia and also hypophosphatemia. And this again indicates tubular leak of phosphate and indirect measurement of renal tubular toxicity of Tenofovir, TDF. So another study from Italy showing reduced renal safety by TDF, and also another Italian study also shows that there's a hypophosphatemia and also diminished EGFR, indicating glomerular injury. So altogether, all these data show that TDF, although it's actually very safe altogether, but in a small proportion of patients, we do see concern in terms of renal impairment, tubular leak of phosphate, which may directly or indirectly associated with reduced bone mineral density. So in UK, people have actually looked in the bone mineral density of HPV monoinfected patients, and they use the X-ray densitometry to look into the impact of TDF on the bone. And it was found that TDF was associated with lower hip T-score as compared with no TDF. So this actually echoes very well with the Hong Kong study, when we see more hip fracture in patients taking Entecavir. And here, the British actually, they saw a lower hip bone mineral density as compared to no TDF group. So hip seemingly is more vulnerable than the spine to the bone effect of TDF. So with renal and bone problems at the background, what we are seeing is actually an aging population. So this is actually an estimate of the world, the age population in the world from 2010 to 2050. Although India is actually not on the chart, but I'm sure India actually shared a similar trend, is that the proportion of patients older than the age of 50 increases with time. Even in Japan, we anticipated more than a third of Japanese will be beyond age of 50 in 2050. And even in China, where I'm living, more than about a quarter of the population will become age older than 50 in 2050. So definitely aging is a major problem. So aging is not just the age. but it is associated with many, many other problems like hyperpressure, renal problem, lipid problem, high risk of diabetes. And we know that for hepatitis B patients who are older, there's a high risk of stage renal disease and also higher risk of osteoporosis. So in these patients, it's even without the effect of TDF. So if with TDF, definitely this problem may be even more exaggerated than the normal elderly patient population. So here I share with you some data and the real world data on renal impairment. And it shows that the risk of renal impairment increases with age in chronic hepatitis B patients. So on the left-hand side, you can see that for those patients older than 60, in the real world data from China, 14% of patients already got chronic kidney disease. And in another study in America, again, 24% of hepatitis B patients at the age of older than 60 already got chronic kidney disease. So this is much higher than a younger population. So as patient gets older in the world, we will see more and more happy patients with renal impairment, and the problem of TDF may become a little bit bigger than what we see nowadays. Now, Bone shared a similar story. So look at the risk of fracture. It actually increases with age, regardless it's men or women. And for those people older than the age of 65, again, the risk of fracture starts to increase. And in another study in patients with Hep B, actually risk of fracture is higher than those with no Hep B. Actually, this is actually reversed. The light blue bar should be with no Hep B, and the purple bar should be the one with Hep B. So with Hep B, there's a high risk of osteoporotic fracture as compared to those without Hep B. Although for osteoporosis, there's a trend, but the statistically cannot show a difference. So for kidney and bone, when patient gets older, we will see more problem, and we should be more cautious to use TDF. So then TAF, tenofovir alafenamide, is actually a new molecule being just introduced into the market. So it's available nowadays in most Western countries and also in some parts of Asia, including in India. So what is TAF? How is TAF different from TDF? So TDF has the characteristics that it has a very short plasma half-life. So after absorption, majority of the TDF will be released as the free active drug called tenofovir. And this tenofovir will be excreted by the renal tubular cells and accumulate there. For those patients who cannot excrete tenofovir effectively, the accumulation of drug in renal tubular cells may cause renal tubular injury. Only a minority of tenofovir will be transported into the where it is diphosphorylated into the active form, and it acts on hepatitis B virus in the liver. So TAF is a much stabler compound. So majority of the drug will be delivered into the liver. Only very small amounts of free tenofovir is left, and therefore it will not overload the phase 2 randomized study. So to start with, we do not know how much TAF is needed. Phase 2 study, 4 doses of TAF were tested, but in only 4 weeks from 8 milligram daily to 120 milligram daily in only 10 patients per group. And the control arm was TDF. And patients being chosen for this study are patients with high DNA, normal to up to 10 times normal ALT. And this study was performed in Australia, Canada, New Zealand, UK, and America. And patients were treated for 4 weeks and then followed up afterwards. So what we saw was actually a very effective viral suppression. The orange line is TDF, and the rest are all TAF. And you can see that the lines are almost clumped together. There was actually no difference in terms of viral decline over the range of 8 milligram to 120 milligram TAF. and the viral suppression in 4 weeks of TAF is very comparable to what we see in TDF. And therefore, the company eventually picked the second lowest dose of TAF, 25 milligram daily, into phase 3 study. So in phase 3 study, this is one of the biggest study in the history of hepatitis B development. So this is called 108 study and 110 study. 108 study is for negative genotypes that we can have in the world. So in 108, that is a negative study, 10 of 110 sites are actually from India. So India represents a very important country in this study, and definitely the result of the study can be applied in India. And you can see that India has 33 patients included in this study, which is actually one of the highest recruiting countries in the world. For 110 E-positive study, there are 19 out of 161 sites are also in India. So therefore, again, very important country in this study. If you look at the Indian site, India has included 110 patients. Actually, it came up third in terms of recruitment, in terms of country. Korea comes first, and then followed by Hong Kong and India. So definitely, the data of this study can be applied in India. So what's the data? So number one, look at the efficacy data. So you look at E-negative patient, and on upper panel, E-positive patient in lower panel, and look at DNA undetectability as an outcome measure. And you can see the negative patient, more than 90% of patients had undetectable DNA at week 48. And then again, about 90% of patients had undetectable DNA at week 96. There was no difference between TAF and TDF at both time points. Similarly, for E-positive patient, we see exactly the same, although because these patients have a higher DNA at the baseline. So it's more difficult to suppress the virus in these patients. In 1 year, only about 60-something% patient had undetectable DNA. And with prolonged treatment up to 2 years, more than 70% of patients had undetectable DNA. Again, there was no difference between these two drugs. So in other words, in terms of antiviral efficacy, there is no difference between TDF and TAF. And actually, no drug resistance was found in both arms up to week 96. So when we look at the E0 conversion data, it's not too impressive, but there's actually no difference between the two groups in terms of E loss, and TAF seems to have a higher rate of E0 conversion as compared to TDF at the end of week 96. But the number is actually not too high because only 18% of TDAF patients and 12% of TDF patients had E0 conversion. Some people may ask, well, is it too low as compared to past trials? I must say that because of the decrease in a normal ALT definition. So the patient we recruited in this study in general have a lower ALT level than study in the past study, lamivudine and Entecavir registry studies. And because of a low baseline ALT, we anticipated that there's a lower chance of E0 conversion. So it is the beauty of a randomized control study that can we really see that there's actually no difference between these two drugs. S loss is uncommon. Only 7% in TAF group, none of the patient in TDF group. And as S0 conversion, only 6 patients in TAF group, no patient in the TDF group. So this is very compatible with the S loss rate in other drugs. So in other words, in terms of viral suppression, I must say, TAF is not inferior to TDF. If not, it has a higher E0 conversion rate. Now, but the interesting thing is on ALT normalization. So in E-negative patient, again, upper panel, E-positive patient in lower panel, and we use 2 criteria to define normal ALT. One is the central laboratory criteria. So this is based on the central lab. ASLD criteria is 13 men and 19 women. So with the 2 different definitions of normal ALT, we can see a consistently higher proportion of patients who can achieve a normal ALT in the TAF group as compared to the TDF group. So no matter these patients are E-negative or E-positive, or no matter which criteria we use. Now, up to today, we do not have a good explanation to why why more patients on TAF have higher normalization of ALT. For this, more studies are going on. We are not certain whether it is disease-related or drug-related, but definitely this is a good thing. So this is actually good news for TAF because we know that patients with normal ALT level have a lower risk of long-term liver-related complications. Now this is actually the abstract I presented in ASLD a few months ago, and we have a very stringent criteria to screen for viral resistance for patients on TAF. So we try to survey the VID96 viral resistance for all patients who have a detectable DNA of VID96, all those patients who discontinued TAF at the time when the DNA was higher than 96. And for all patients, we perform direct sequencing. And for those patients who have viral breakthrough, we also perform a phenotypic analysis to see if there's any phenotypic drug resistance. So with all these very sophisticated and thorough assay, we know that majority of patients who have viral breakthrough are actually non-adherents, or those patients who had residual low viremia. So this is a patient of non-adherence. So the black bar is patients not taking the drug. We do not find the level of the drug in the serum, and you can see a rise in viral load. So this is definitely not drug resistant. This is the example of patient with low viremia. That is patient with very low viremia, and then there's a kick of the HPV DNA. And this is patient with viral breakthrough. That is patient with undetectable DNA, and the DNA goes back. So there are only a much small minority of patients who had viral breakthrough with no evidence of non-adherence, but no resistance was found in these patients. So when we go to safety, there are two key concerns. Number one is kidney. So this is the mean eGFR reflecting glomerular function. Yellow line is TAF, blue line is TDF. You can see this a slight reduction of the eGFR among patients on TDF, which is persistently lower than the line on TAF. And the difference was significant statistically at both week 48 and week 40 and week 96. Yeah, and you can see that the yellow line is almost stick to the baseline. So there's almost zero impact of TAF on the eGFR over 2 years. So this is bone mineral density, and we look at the bone mineral density in hip and also in the spine. Again, yellow line is TAF, blue line is TDF. And you can see a decline of bone mineral density in both the hip and the spine. Although there's no clear statistical test that we can use, we can see the spine decline seems to flat out after 24 weeks, but the hip decline actually keeps decreasing with time. So that may be the reason why in the UK study and also in Hong Kong study, we found that the hip seems to be more vulnerable to reduce bone mineral density and fracture than the spine among patients on TDF. But we look at patients on TAF, again, yellow line is almost sticking to the baseline. There's almost no change of BMD throughout 96 weeks on TAF, and definitely the decline was much smaller than patients on TDF. So we try to look at the bone mineral density change from another angle. That is a more than 3% change, because we always think that a very small change, less than 3% change, may not be significant clinically. So we look at TAF and TDF and hip. The proportion of patients with more than 3% change is actually very small. And in the spine, again, it's actually very small. But on TDF, patients with more than 3% change is actually much bigger. For patients with more than 3% improvement, that is the dark blue line, it is slightly more on patients on TAF in both hip and spine. So overall, as you can see, patient on TAF, it is more blue, and patient on TDF is more red, which is a decline in bone mineral density. Now for this study, the design is not smooth at all. In the early protocol, the first protocol, the randomized phase was only for 2 years. And then we plan to observe for 3 more years in open label. But in the middle of the study, FDA suddenly requested the protocol to be amended, that they requested the randomized phase should be extended to 3 years and then open label study for another 5 years. So in other words, there are some patients who have stopped treatment in the original protocol before FDA enforced the protocol amendment. Therefore, we have some patients who have to switch from TDF to TAF in the preliminary analysis. So here, among patients who switch from TDF to TAF, we can see that there's actually no difference among patients who are continuously on TDF or those patients who switch. In other words, it supports the similar antiviral suppression efficacy of the 2 drugs. But if you look in the ALT normalization, it's actually interesting to see that for those patients who are already on TDF, original TDF, but then switch to TAF, only for half a year, the ALT normalized in more patients. So this supports, again, that TAF is associated with a higher ALT normalization. It seems that the improvement is very, very fast because in only 24 weeks, there's an increase of 18% of patients with normalized ALT level in the switch group. So here again, we try to look in the switch. The blue is TAF, orange is TDF, and the green is the switch. So here is the creatine clearance on the left, bone mineral density on the right. So if we focus on creatine clearance, we know that TDF is associated with decreasing creatine clearance as compared to TAF. The interesting thing is here, after week 96, for those who switch, you can see there's an increase in creatine clearance in 24 weeks, although it has not yet reached the level of patients on TAF monotherapy, but the trend is clear, and the p-value, that is the difference in creatine clearance among the switch group at week 120 as compared to week 6 was already statistically significant. So there's an improvement of renal function if we stop TDF and switch to TAF. So similar thing we see in bone mineral density. Again, the blue line is TAF, the orange line TDF, the green line is a switch. In both the hip and the spine, we see a clear improvement in bone mineral density after we stop the TDF and switch to TAF. And the change between week 96 and week 20 are all significant in both the hip and the spine, although it has not yet catch up to the group on TAF monotherapy, but at least a trend is there. So looking at all this, we know that for those patients on TDF, if we switch to TAF, we can anticipate an improvement in renal safety, improvement in bone mineral density, improvement in ALT normalization without compromising the viral control. So here's the safety data. So safety is actually very important in terms of TAF and TDF. So when we look at the serious adverse events at week 96, there's actually not much difference between these 2 drugs. Because if you look at the phase 3 data of TDF, we do not see many serious adverse events with TDF, and with TAF, again, it's actually very safe. For laboratory abnormality, in general, it's the same. There's actually one worry. Some people say that the LDL level can be higher in TAF patients. Well, actually, TAF is lipid neutral, but TDF has been shown to reduce LDL in some patients. And that's the reason why we may see a seemingly worsened lipid profile of TAF. Actually, it is an improvement of lipid profile in TDF. But this is, again, only a very small percentage of patients, and the improvement is just a numerical improvement. It doesn't mean that it is a clinically important or significant improvement. So putting all the data together, we know that TAF is a new drug, and it is if you like cars, I would say this is a facelift version of TDF in the treatment of chronic hepatitis B. So the couple of advantages in terms of efficacy, it has almost the same ability to suppress HPV DNA, so we're not compromising the antiviral efficacy of TAF. And with the 8-year data of TDF, we can anticipate that similar thing will be seen among patients on TAF. And there's absolutely no drug resistance of TAF similar to TDF, at least up to week 96. The good thing is patients receiving TAF have a significantly increased rate of ALT normalization as compared to TDF using ASLD criteria and also the laboratory criteria up to week 96. The best thing over TAF is the safety because it has significantly less impact on bone mineral density at the hip and the spine. It has significantly low impact on EGFR and tubular function. And even for those patients who have been on TAF, if you switch to TAF, it seems these two adverse events can be reversed. And it's just a matter of time when it goes back to the normal level. So the last thing is about patients with already renal impairment. I have not shown you the detailed data, but actually TAF can be given to patients with a creatinine clearance up to 15 ml per minute. So for those patients with the creatinine clearance more than 15 ml per minute, you do not need to reduce the dose. But for TDF, dose adjustment has to be started for patients with creatinine clearance less than 50 ml per minute. So TAF is a much friendly drug to use, much easier drug to use, even in patients with mild renal impairment or moderate renal impairment. So this is the latest EASL guideline integrating all the evidence of when to use TAF and when to use TDF. So for most patients with no comorbidity, then actually the first-line therapies are still Tenofovir, Entecavir, and Tenofovir alafenamide. There are some conditions that we favor the use of Entecavir or Entaf, TAF, over TDF. Number one is elderly, because we know that elderly patients have more renal disease, more bone disease. So we have to be very careful if we want to use TDF. Patients with bone disease, again, we don't want to exacerbate the bone disease, particularly like patients on steroid or the medicine that increase risk of osteoporosis. Any patient with history of fracturity fracture, and for those patients with no osteoporosis, we do not want to use TDF. For those patients with renal impairment, again, you do not want to use TDF. For those patients with EGFR less than 60, for those patients with albuminuria, proteinuria, low phosphate on TDF, which may already indicate a tubular leak of phosphate and tubular toxicity, and those patients on hemodialysis. But there are in some situations that Entecavir is not as good of TAF, even we do not want to use TDF. Number one is those patients with past exposure to lamivudine or even Entecavir resistance. So these patients may share cross-resistant mutations with ETV and have a higher risk of Entecavir resistance. So TAF will be the first choice of drug. The second group is HIV-HBV co-infection, because Entecavir has a weak anti-HIV activity. If we use Entecavir, you may induce resistance to HIV. So this is something we don't want to, and definitely TAF will be a better choice than Entecavir. And also for those patients with more mild to moderate renal impairment, because we do not need to adjust the dose for those patients with creatinine clearance more than 15 ml per minute. For those patients with very bad renal impairment, we do not have data with TAF, so I will still recommend you to stick to Entecavir, because we do have guidelines how to reduce the dose of the Entecavir, but we do not know how to reduce the dose of TAF yet. But in the future, this may change. So this is actually my summary slide. I hope my presentation will help you. When TAF arrives in the market, you will know more data on TAF, what's the benefit of TAF over TDF. This is important to communicate to patients. And for those patients on TDF, particularly for those with bone and renal impairment or risk, I will recommend you switch to TAF, and it is very, very safe and definitely can rescue some of the bone and renal impairment. So I welcome any question from you, so we can start the question and answer session. Okay, wow. I've got some questions already. Let me see whether I can summarize some of these questions and then focus on them. Okay, now one important question would be the goal of treatment of hepatitis B. So the short-term goal is still virus suppression, because we know that when we suppress the virus, we can already reduce cirrhosis complications and also reduce cancer risk. The ultimate goal is, of course, the reduction of mortality and also reduction of complications. So the goal has not been changed. But nowadays, some people are talking about functional cure, and this also go to another question about is a cure of HB infection possible? There are a lot of new drugs being investigated. These are all in early phase studies targeting a different viral replication target like sRNA, capsid inhibitors, HBsAg release inhibitors, and also there's some laboratories that look at drugs looking at cccDNA, and also there's some new immune modulators, for example, toll receptor agonists, therapeutic vaccine, but none of these drugs have passed phase 2 study. So we still need to wait for a while, maybe for a few years, before we know which drug will come up as a new therapy. But even if we have a new drug, it does not mean that we do not need a nuke, because a nuke is still the most potent drug to suppress HBV DNA, and probably TAF will be the backbone of future antiviral therapy. So another, actually, a few doctors actually asked about the choice of treatment. So which drug do I recommend starting first-line agent, TAF or ETV? Well, this is actually a question with a easy answer, because both drugs are good. In majority of patients, I must say I cannot see any clear difference. But the important thing is, particularly among patients previously exposed to lamivudine, that I will try to start TAF. For those patients who have renal impairment that you do not want to adjust the dose, or those patients with HIV co-infection, I will try to start TAF. But for others, well, actually these two drugs have very similar performance, although there's no head-to-head comparison. So for another question is about E-negative patients, because in India has a high proportion of E-negative patients, and which drug do I recommend starting? Well, I think E-negative in general have a lower HBV DNA as compared to E-positive patients. So to me, it's easier to suppress group of patients, and I do not see any difference in terms of TAF, TDF, and ETV. But of course, for those patients who are older, because E-negative patients are usually older, and I'll be more careful on the key in the bones, and TAF will become a better choice than TDF. For diabetes, I've actually got another question that India has a very high preference of diabetes. Yeah, for this, I'm fully aware of that. So the question is, would TAF be preferred over TDF in diabetic patients with the risk of diabetic nephrotoxicity? Now, number one, there's no data on whether TDF will worsen diabetic nephropathy. Of course, for those patients who have already overt renal impairment, I clearly will favor TAF. But there are some early diabetic patients, they do not have renal impairment yet, and there's no evidence suggesting that TDF will hasten the process of developing diabetic nephropathy. So for this patient, to me, it's still, the choice is still open, whether you use TAF or TDF. But if you pick TAF, I don't see any harm, because definitely it is much renal friendly, and it's actually more a peace of mind for the doctor and for patients. And I also see a question about younger patients, because the EASL guideline recommend using TAF in older patients. But how about young patients? Well, I must say that up to today, we still do not see TAF as a therapy of functional cure. In other words, patients still need to take the drug for a long time until new therapy arrives. Therefore, in younger patients, although they're younger, so they theoretically speaking have a low risk of bone toxicity, but it also means they have to take the drug for longer. So to me, I definitely favor TAF over TDF for younger patients, particularly if I anticipated this patient may need to take a drug for decades. And even when they're young, the bone is stronger, but if you have a longer time to weaken the bones with TDF. So yeah, I agree with you. I support to use TAF over TDF in younger patients, although it is not clearly stated in the EASL guideline. But you know, guidelines changes every 3 years. So maybe in the future, with these questions, the guideline may change. So pregnancy is a interesting group. I also received a question on pregnancy data. Up till now, we do not have pregnancy data in TAF. So the recommendation is TDF is still the drug of choice because in pregnancy prophylaxis, particularly among patients who do not need long-term drug, then the risk of TDF is very, very low. And we only cover those patients for the 2nd to 3rd trimester and at most of up to 12 months after delivery, and then we can stop the drug. And with this short duration of therapy, TDF has a very, very good safety profile. And right now in the latest American guideline, after looking into the breast milk safety, TDF can also be used during breastfeeding. So at least at this stage, TDF is still the drug of choice in pregnancy. New trials will be done for TAF. But before we have the new data coming up, I will not recommend to use TAF in this sensitive group of patients. So another study is another question is for the use of TAF in dialysis patients. Well, right now we do not have data yet. There is a study ongoing testing patients on dialysis. So in that study, patients on hemodialysis will not change the dose, and we will see the data from that study before we can recommend whether there's any need for dosage adjustment. Peritoneal dialysis, I must say there's actually no data. So patients on peritoneal dialysis, data for all antiviral drugs are very scanty, and we will still base on the eGFR to adjust the dose, and we do not know how to adjust the dose in these patients on TAF, so probably it would be better to use drugs, particularly ETV, because we know how to adjust the dose in these patients. So the other important question is switching. Actually, I received 2 questions on switching. So what's the benefit of switching from TDF to TAF? Well, as I presented, switching, number one, will not compromise viral control, but clearly switching can reverse some of the renal adverse effects and also some of the reduction in bone mineral density induced by TDF. And also, there is a higher rate of ALT normalization in patients on TAF, switch to TAF as compared to those who are on TDF. But yeah, the clinical relevance of ALT normalization is actually very difficult. Actually, this is actually one question addressing on this. So we know that ALT normalization is good, but we do not have long-term data comparing the TAF group and TDF group. And definitely with this small difference in proportion of ALT normalization, that is about 15% and 20% difference, I don't think it's easy to see a hard clinical outcome. But actually our group has performed a study on ALT normalization as versus long-term outcome, and we found that those patients with normal ALT actually tend to have a better long-term outcome in terms of cirrhotic complications and also liver cancer. For renal, for after switching of TDF to TAF, one question is how long does it take to see the benefit? Actually, we started to see the benefit in 24 weeks, but we see more benefit in 96 weeks. So there is actually one study ongoing, recruiting patients on TDF, switch to TAF, and it's just started globally. So we may need a few years before we see whether patients on TDF, they will have all the renal and bone safety back to TAF level, that is the normal level, after a few years of switching. So for this, we don't know. But we know that the improvement is continuous. You can see an upslope from time they switch of TDF to TAF up to week 96. The slope is still upgoing, so we can anticipate more and more improvement in renal and bone after switching. But if we switch from ETV to TAF, there's another question on this. I must say I don't know. There's absolutely no data, no study on switching ETV to TAF. The key benefit I can think of will be among patients, particularly with past exposure to lamivudine. So there's a much lower chance of ETV resistance. But otherwise, there's no data at all addressing patients switching from ETV to TAF. So another question is the use of TAF in decompensated patients, that is liver cirrhosis patients. Now, there's no data yet, but we have data on TDF. We know that TDF is very safe in patients with decompensated cirrhosis, and patient on TDF actually has reversal of fibrosis and also reduction of MEL score and Child-Pugh score, and patient can be taken off the transplant list on TDF. Because TAF is much safer than TDF, we are using a much lower dose of the drug. It's the same active drug, so I cannot see any reason why TAF will not reproduce exact benefits. Well, we need to see data. There's a study ongoing, but frankly speaking, I'm actually quite comfortable to use TAF in patients with decompensated liver cirrhosis. There's a question on money. Since India is a resource-limited country, what minimum markers do we need to test to screen for bone and renal toxicity? Well, this is a very good question, because if you look at the clinical trial, we are testing a lot of very sensitive markers, and these markers are never used in clinical practice. It's extremely expensive and extremely hard to find. You may not be able to find a lab doing it. So the basic markers to look for bone and renal toxicity for kidney, number one is serum creatinine. So you can also convert this into eGFR by the MDRD formula, which is very easy. You just need to know the age, the gender of patients, and then you can convert. There's an online tool for that. It is free. But the renal tubular toxicity, one indirect marker is a serum phosphate level. If you see a drop in serum phosphate level, or you can measure the phosphate level in the urine, if it goes up, it means that there's tubular leak. It indicates renal tubular toxicity due to TDF. For bone mineral density, I must say we do not have a good marker. I do not recommend regular DEXA scan for all patients because number one, it is expensive, and number two, you may expose patients to unnecessary radiation because it's still a CT scan. So we will always look in the serum phosphate level because we know for those patients who have tubular leak of phosphate, they have a higher chance of bone loss. You can also look at ALP, alkaline phosphatase, because alkaline phosphatase is a marker of bone turnover. For those patients with high ALP level, it may mean that these patients have a higher bone turnover and they have a higher risk of bone loss and reduction in bone mineral density. So I've got one question, Charles B, Charles C. We have no data, as I've just explained, but definitely TDF is safe in both, and I think TDF should be okay in both, although we're doing a study on that. Lactating mother, we have good data on TDF. We don't have data on TAF yet, although I believe that it should be even safer because we're taking even less tenofovir, and the tenofovir is more focused to work in the liver. But I think we need more data before we can make this recommendation, and therefore in most guidelines, TDF is still the drug of choice. And as I've said, because you're still actually using a drug for a short time, you stop the drug about 12 weeks after delivery. So the toxicity of TDF may not be a big concern in prophylaxis for pregnant women. For the toxicity, mitochondrial toxicity of TAF versus TDF, well, actually TDF is a key drug in HIV treatment. And actually we do not see mitochondrial toxicity. And the same thing is actually with TAF. We have preclinical data suggesting that T8 is actually have no mitochondrial toxicity, and it is very, very safe to use in patients. So in HIV patient, HPV patient, it is actually very, very safe to use. So yeah, I thanks a lot for all the questions. I must say all these questions are extremely relevant. They're very important. But for some of the questions, we do not have data yet. To summarize it, is pregnancy, we don't have data. For patients with end-stage renal disease and also decumbent cirrhosis, we don't have data. But there is a study doing it. This is a 40-35 study, which is ongoing, a global study. For those patients who have a switch, right now we only see preliminary data of the benefit because this is not a planned analysis. It is just a beautiful mistake because of the FDA requirement of protocol change. But we are now doing a proper randomized control trial to look into the switch of TDF to TAF. That is a 40-18 study, and both studies are ongoing right now, and I'm sure you will see some of in a meeting.啱啱好，就咁多字唔使講。OK，good，係佢哋好多問題嘅，通常係。係咯，係嘛？好多問題嘅，咪有啲係妹嚟嘅，咁但係有啲就係堅嘅。係嘛？咪 San J 係妹嚟㗎啦。San J 係咯係咯。係啊，San J 係妹。